Hello class, today we have a micro-learning session on bradycardia. So some learning objectives for today: we're going to recognize the signs and symptoms of bradycardic rhythms. We're going to demonstrate appropriate nursing interventions with these bradycardic rhythms we're going to learn about. And we're going to identify when and how to escalate care. So what is bradycardia? And I wanted to put some of these heart rhythms in big bundles because they're treated very similar to each other. So bradycardia is a heart rate slower than 60. Let me get my good pen back. Slower than 60. And it could be originating from a lot of areas, but we're going to say slower than 60. And it may be normal or abnormal depending on the client, right? So we might have some athletes coming in that might have a heart rate lower than 60, and that's okay. So it could be asymptomatic, or the patient could have a lot of symptoms, even causing them to pass out. Common causes that we're going to look at: vagal stimulation is a common one, medications, heart blocks. The medications are a big one, such as our beta blockers, slowing them down. And then we're going to do the treatment based on what's going on with our patient. Do they need something aggressive, or can we be a little more conservative in our approach? So some of the rhythms we're going to learn today, and I actually will have pictures of all these for you too on the following slides: sinus bradycardia, junctional bradycardia, and idioventricular rhythm. So what distinguishes these? Well, all of their heart rates, if you look down the chart here, are less than 60. The P waves is where we really start getting interesting. Remember, our P wave is what originates the cardiac cycle, right? So our P wave right here at the beginning for a sinus will be normal. For a junctional, may be absent or upside down, inverted. And then for idioventricular, because it's coming from the bottom of the heart, that'll be absent. PR intervals, you see them there. Our QRS complex, the only one I really highlighting here, we'll have normal ones on the top. Our wide complex down here with idioventricular, because it's coming from the bottom of the heart. So key features: SA node for our sinus bradycardia. Junctional is usually from our AV, which, remember, the AV, if I was to draw a little heart here, is right about there. SA up here, AV, where the atria meets the ventricles. And then our treatment associated with these. So coming out of the picture here so you can see it better, many times we're just going to monitor our sinus bradycardia, but they may get atropine. They may get atropine and junctional. And then many times idioventricular, they're going to be in a cardiac arrest and kind of coming out of that cardiac arrest or sub-arrest. So our first rhythm here, sinus bradycardia. Why is it sinus? Well, we have a P wave, right? So it's coming from the sinoatrial node. It's coming from the top of the heart, right? Way up here. The only difference between sinus bradycardia and sinus rhythm is less than 60. That is it. So as long as you know sinus rhythm, you know sinus bradycardia, because it's just less than 60. Our next one here, junctional, and I made this junctional very easy because I took away the P wave, right? We have a rate here, if you were to count it, 1, 2, 3, 4, 40 beats per minute, and I took away your P wave. So I took that P wave away. It also could look like this. Could just be inverted. So we could have a inverted P wave. That's another option with our junctional rhythms. And then our idioventricular rhythm. Remember, this is coming from the bottom of the heart, right? When we get down to those Purkinje fibers, all the electrical impulses from the bottom are going to be very slow when they're originating. So no P wave at all, 0 P wave, and then a wide complex greater than 0.12, our QRS, wide complex, right? And this is a slow wide complex rhythm. So what do we do? You learned the 3 heart rhythms here. What do we do about these? Well, we're going to assess for symptoms. Is our patient having anything? Now, I would tell you with idioventricular, they're probably unresponsive, so that would have pretty big symptoms. But for other ones, they may have no symptoms at all, or they may have some chest pain, they may have syncope. We have to see what's going on with them to decide our treatment algorithm. The next thing we're going to do is, if our patient is sinus bradycardia or even some junctional, we may give a test dose or a treatment dose of atropine, right? Atropine does a very great job. It's part of ACLS handbook for initial rhythms of bradycardia. We'll give that every 3 to 5 minutes. And you know, we don't have to know dosing, but I put it here for you. Up to 3 milligrams is the total dosing. If the patient is unstable or something changes, that's when we can start going into transcutaneous pacing. And that is where you're going to put the pacer pads on your patient, and you are going to guide their heart rate. So if their heart rate, when they got to is 40, you're going to set your rhythm and say, now your heart rate is 70. And we're going to shock you until you get to that heart rate. And if the patient's even remotely awake, they'll start twitching because the shocks are continually being given to them. So that is the backup option if atropine doesn't work. The other thing we could do, you learn maybe some of these meds during adult 2 courses and during pharm, is norepinephrine. This is also levofed, or just standard epinephrine. So those are other options for drugs. We're going to identify and treat the underlying cause. What brought the patient here? What made this heart rhythm? And then how do we fix it? So let's look at some questions. How would I be asked something like this? So your client comes in, chest pain, is now reporting feeling lightheaded. Okay. The telemetry monitor shows a heart rate of 42, and it has a regular rhythm and visible P waves. Regular rhythm, 42 visible P waves. Okay. So I'm thinking probably sinus, Brady, right, as my rhythm. What is your priority action? Well, we know they're lightheaded and we know their heart rate's 42. What are we going to do for them? Continue to monitor and reassess, immediately call the rapid response, prepare for transcutaneous pacing, administer epi 1 milligram. So what do you think we should do? So the patient is admitted for chest pain, is now reporting feeling lightheaded, they're not feeling well, and they have a heart rate of 42, and their blood pressure's okay, but what do you guys think? What do you guys think the priority action for this? Well, I don't think we're going to give epi because their blood pressure's okay. I don't think at this point they need transcutaneous pacing because, they're making a good pressure. Continue to monitor and reassess. That could be, but the patient's having a new onset symptoms with a change of rhythm. So continue to monitor and reassess. If we take the lightheaded out and have a normal heart rate or a low heart rate but a good blood pressure, and this is their normal, this could be the right answer. But they're having a new heart rate with lightheadedness on a chest pain admission. So what do we want to do? We want to initiate that rapid response team, have them come to the bedside and assess our patient. The client presents with dizziness and fatigue. The monitor shows sinus Brady at 38, very slow. Blood pressure is 102, borderline. And the client is resting comfortably in the room. Okay. What action should the nurse take? All right, let's think about this. What do you guys think? Where are we at? So we have a somewhat stable patient. They have dizziness, fatigue. They do have a low heart rate. Blood pressure is okay, but they're resting comfortably in their room. What are we going to do? Adenosine, hopefully you're thinking that is for patients with tachycardia. Transcutaneous pacing, it's an option, but look at our pressure. We're not altered. We're resting comfortably and our pressure is greater than 90 systolic, so probably not the best option. Prepare for synchronized cardioversion. Do we need a cardiovert of 38? No, right? They're slow. They're not in VFit or VTAC. They're not in SVT where we're going very fast. We don't need to do anything as far as shocking them in that state. So we're kind of left with atropine down here at the bottom, which is a great option to speed up that heart rate and just give them some medication management. So some key takeaways from today. Bradycardia is defined as a heart rate less than 60 and maybe normal. An example for that could be athletes. Or it could be an underlying disease process like a heart block or others, and I'll talk about heart blocks in a separate video. Symptoms such as dizziness, hypotension, syncope could indicate that something needs to be done rapidly. Initial treatment for symptomatic bradycardia is atropine. That is the initial treatment, and then we kind of go from there, right? So we give them some atropine and see if it improves, and if it doesn't improve, that's where we can go to pacing or meds. And dopamine, I'm not a big fan, but it was part of, in some of the books, really we like levo, as in levofed, or epi. Always assess for treat underlying causes. There could be the patient took too much of their beta blocker. They could have an electrolyte issue. They could have been hypoxic, like a COPD patient, and that could be what's causing them to have this bradycardic rhythms. So, hey, thank you guys so much for joining me today.